Hello, I'm Atsushi Hirayama from the Division Cardiology, Department of Medicine, Nihon University School of Medicine in Tokyo, Japan. Welcome to this presentation titled Screening, Identification, and Management of Patients with Familial Hypercholesterolemia. This slide shows the cause of death in heterozygous FH in Japan. 66% of men and 55% of women FH died because of myocardial infarction or sudden cardiac death. Mean age who died in FH is 63 years old in men and 72 years old in women, which is significantly younger than the mean average age in Japan. This is a case with 30 years old young FH patient who suffered from acute coronary infarction. Coronary angiogram showed the occlusion of proximal LAD, and IVUS of the proximal region showed the large plaque burden. His LDL cholesterol level is 398 mg per deciliter, and his Achilles tendon is 9.5 mm widest. FH is autosomal dominant genetic cause of premature coronary heart disease, as shown previously. This slide shows the prevalence of familial hypercholesterolemia among genetic disorders. Familial hypercholesterolemia is more common than other genetic disorders. The prevalence of FH globally based on the estimated incidence of 1/500 or 1/200. Based on this estimation, 3.6 to 9 million FH patients are in Southeast Asia. This graph shows the relationship between the accumulation of LDL cholesterol and the threshold called the coronary artery disease. The threshold is modified by the sex and several other risk factors. However, LDL cholesterol is a main factor. In homozygous FH, exceeds the threshold in young age. In heterozygous FH, the onset of CAD is a little bit later and modified by statin treatment. Thus, the LDL cholesterol lowering therapy should be done early as possible to avoid cardiac event. So, reason for necessity of early diagnosis of FH. FH is high risk for atherosclerotic cardiovascular disease due to the long-term high LDL cholesterol exposure after birth. CV event could be prevented by early discovery following appropriate treatment. Cascade screening could identify the high-risk FH for prevention of CV event. Thus, the screening should be performed as early as possible. However, the only 1 or less than 1% of FH is diagnosed in Asia region compared to the Western country, because most countries in Asia do not have valid nationwide registries for familial hypercholesterolemia. Another reason for the difficulty to diagnose the FH is the wide range of LDL cholesterol level of FH patients. This slide shows the distribution of LDL cholesterol level in Japanese patients with FH shown in red. The LDL cholesterol level range from 450 to 130 mg per deciliter in FH patient, and there are overlap among the patients with and without FH, indicating that it is very difficult to diagnose FH based on the only LDL cholesterol level. Although FH is known as the autosomal dominant genetic disorder, there are many known mechanisms causing familial hypercholesterolemia linked to LDL cholesterol receptor function, as shown in this slide. These were no universal genetic screening method to find out FH. The slide showed the genetic variance among Japanese FH patients in Hokuriku district. 72.6% is LDL receptor abnormalities and 6.6% in PCSK9 abnormalities. Many gene abnormalities are found in Japan. Based on the population, 1/293 people has LDL cholesterol receptor abnormalities, and 1/222 has PCSK9 abnormalities. Taken together, 1/199 is FH on the basis of population. No patient with ApoB abnormalities are found. The Dutch Lipid Clinic Network criteria used widely for systematic diagnosis of heterozygous FH. This criteria used a score based on the familial history, clinical history, physical examination, LDL cholesterol level, and DNA analysis. This is widely used in Europe. However, the definition of FH is different from each country. The slide shows the diagnostic criteria of FH studies in Asia. Some studies are the Simon Boom FH registered diagnostic criteria. Others use the DLNC diagnostic criteria or MedPair criteria. A few studies use their own criteria like Japan. In Japan, we use the original diagnostic criteria according to the Japanese Atherosclerotic Society Guideline 2017. Heterozygous FH is diagnosed according to the criteria fulfilled 2 or more of 3 criteria, that is, first, LDL cholesterol level 130 mg per deciliter and more. Second, tendon xanthoma. Third, family history. But it is very difficult to measure exact tendon xanthoma according to the standard method. So it is difficult for the generalized screening in clinical practice. We focused on patients with acute coronary syndrome. Among acute coronary syndrome patients, 5.7% fit the criteria of FH. In case under 60 years old, 7.8% is FH. The prevalence of FH among ACS patients is not low, and these patients should be treated by intensive LDL cholesterol lowering therapy for the secondary prevention. The cascade screening also should be done to prevent CV events of the next FH patient. Treatment strategy recommended by JAS guideline is shown in this slide. Patients with FH over 15 years old should be treated by statin first. The target LDL cholesterol level is different from patient's condition. After maximum tolerant dose of statin with or without ezetimibe does not reach the target LDL cholesterol level, PCSK9 inhibitor should be applied to reach the target LDL cholesterol level. According to the MedPed program, the rate of diagnosed FH patient is very low in 4 Asian countries. However, statin treatment is highly performed in Japan and Singapore, but the prevalence of well-controlled patients are still low. Thus, the treatment of FH is not enough by using statin only. PCSK9 inhibitors should be used widely for the prevention of CV events in FH patients. Odyssey FH first and FH second are the 2 randomized double-blind studies to assess 78 weeks alirocumab treatment in patients with heterozygous FH and inadequate LDL control on maximally tolerated lipid-lowering therapy. After 78 weeks of treatment, the percent reduction of mean LDL cholesterol level from baseline versus placebo was 51.8% in first FH and 52.1% in second FH. Rutherford second is a multicenter randomized double-blind placebo-controlled trial to evaluate the effect of evolocumab on the LDL cholesterol level in patients with heterozygous FH treated by lipid-lowering therapy. Compare with the placebo evolocumab at either 140 mg biweekly or 420 mg bimonthly led to a significant reduction in mean LDL cholesterol at the end of the study by 60.2% to 65.6%. The effect of LDL cholesterol reduction by evolocumab was also shown in the part of UCAVA2 study. Although the number of FH is few in each group, the significant reduction of LDL cholesterol level by evolocumab was observed in Japanese FH patients treated by statin. The reason for the significant reduction by evolocumab is due to the increased PCSK9 production after the statin treatment. So I would like to give you a key message to the general practitioners. Familial hypercholesterolemia is common genetic disorders. FH patients suffered atherosclerotic cardiovascular disease in premature age. Suspect FH when LDL cholesterol over 180 mg per deciliter. Family medical interview, including family history, is important. Careful physical examination should be done. Cascade screening should be tried to identify another candidate. Early appropriate LDL lowering is required to achieve the target LDL cholesterol as early as possible by using statin and PCSK9 inhibitor. And now please answer the question to evaluate your learning. And thank you for participating in this Medscape activity. Please continue to follow the other video presentations.